Можно с 3D начать. Hello dear colleagues, my name is Mynzhylky Berdikhojayev. Together with my colleague Ravan Maratlı, we are from Almaty, Kazakhstan. It's a country in Central Asia. And now we have a patient with headaches, and the patient went for MR, and during the MR angiography, our neuroradiology colleagues noticed that patient has a aneurysm. We made an angiography, and now we confirm that in ophthalmic segment there is a microaneurysm and segment is dysplastic. It's aneurysm number 1, and I think it's a problem number 1. This is infundibulum, and the artery is coming from the dome of the enlargement. And okay, let's see the review. Review. Okay, let's see the review. On a review, on the right side, in arterial phase there is no pathology, but we already looked for the MR, and on MR venography, patient has a stenosis in both transverse sinuses, and probably that venous sinus stenosis you can see here. Yes, if you don't used to do venous diagnostics, then usually you couldn't pay the attention for the stenosis. Okay, I asked my colleague Ravan Maratlı to delay the angiography till the end of the venous phase, and now you can see that patient has a transverse sinus stenosis, and on MR this stenosis on the both side. And in my point of view, the headaches most probably from this stenotic portion of the transverse sigmoid junction. Okay, we discussed with the patient first of all, and because of the fear of the patient, we will treat the ICA aneurysm first. And on the right side there is no aneurysm, but on the radiology report it was some enlargement on the ICA territory. But the ICA territory looks clear. There is a ecom artery and everything looks good. And I think the only microaneurysm on the ophthalmic segment on the left side. It's also discussable about follow this segment till the aneurysm will grow or not, this part, but we will respect the patient's fear about the patient's care about this segment, and we will place a FD stent for the ophthalmic microaneurysm. FD, or we can place Leoplast stent, which is also could work like an FD. and I think the 3.5 Leo Plus could be okay. 1 or 2 Leo, and then we will clearly do angiography in venous phase and we'll see. Okay, let's see what kind of stents we have. My assistant Ravan Maratlo, I will repeat once again, and the operating nurse is Bakht. Yes, and the video on company presented by Evgeny Grishayev. He is our partner and friend. He's supporting us for many years. Okay. I think the less is better. And 3.5 Leo baby is better. Осы екеуін ашсын, ішіндегісін. Пока ішіндегісін ашсын. Мынаны просто қасына қойырсыңыз. И Xeon Blue. Okay, for the navigation, okay, guiding catheter is Fubuki through the short sheath, 7 French angled one, and Vasco 21 with the Leo Plus 3.5 25 will place in ICA. Yes, patient already medicated, pre-medicated with the local ticagrelor. It's a generic from Almaty. The name is Triventin, and it's usually effective in more than 98%, and the resistance in our series, I think nowadays is more than 3,000 testing done. 3,000 or 2,500 testing. I think we can join the experience of both presidential and in Astana it's more than 250 testing, and in Almaty more than 400 testing annually. Yes, it's probably 3,000 testing done, and in ticagrelor series the resistance for the ticagrelor in Kazakh population, in Kazakhstani population, there is a Europeans also, Europeoid and Mongoloids mixed, and the resistance is less than 2% for the ticagrelor. For the clopidogrel, with the generics tested, the local generics, with the local generics, the resistance up to 26%. It's quite more, and our colleagues from United States, they reported approximately 6% of resistance, but for our region maybe it's related to the behavior, food, and ecology. The resistance for clopidogrel is quite high comparing with ticagrelor, and unfortunately we have no prasugrel efficient. Prasugrel is not available in the country. That's why we should work with the. That's why we should work with the ticagrelor only. Австралия. Yeah, Australia. болған кезде айтасыз. Болды ғой, да? Все, ауыстырыңыз. Okay, the saline in the flushing system is only half liter. That's why we need to change quite frequent. И экранды бір 10 сантиметр өзіңізге тартасыңыз. To prevent the air embolism. I think this projection is better. It will be okay, 100. Okay, and it will be like the other direction. Okay, 15. Okay. Okay, I gave a J-curve for the Xeon Blue. Xeon Blue is coronary wire. It's a 14 system, and we are very familiar with the coronary wires. And there is a whisper wire, pilot wire, pilot wire, and the Xeon Blue is from Asahi company. And thanks to neighboring with the cardiologists, interventional cardiologists, we started to use Xeon Blue since 2016, I think. We worked at the same cath lab in this hospital for more than 4 years, and time to time I'm visiting them, and for me it's really interesting to know what is the new in the interventional cardiology world. And also I noticed from the Adnan Siddiqui, he has a lot of tools from the interventional cardiology for the ICA chronic occlusions. And yes, the distal 3 centimeter of this wire is quite soft. I want to show you. The length of the wire is nearly 160, 170 centimeter, and distal part is quite stable, but its distal 3 centimeter is soft. And it's very reliable when we place coronary stents and navigate the speed balloon and coronary balloons. Yes, those tools are coming from the interventional cardiology world. That's why they need more stable wires, comparing with the Asahi Chikai Black or Chikai or other narrow wires. It's better to have proper coronary wires, which is more stable. Okay, we can start from the infundibulum of the PICOM to prevent in the future the enlargement of the PICOM. Heparin 5000. It's too distal, I think. Okay, now it's better. Yes, now we're inside. Yes, and it's quite safe and smooth, the navigation inside the stent. and we may confirm that stent is properly opened. And for the small aneurysms, little baby will cause the neo-intima formation, and the aneurysms usually disappear, and we can control with the CT angiography in 6 months, no problem. The possible problem is venous pathology. Okay, the stent is now placed. I will do cranial to check the, okay, it's a palm projection like this. Primary zone. Yes, we have no cartridges for very final system. For some reason, the distributor company stopped delivering the cartridges. That's why we switched for ticagrelor. Yes, it's very important to go with the reliable drug, but it's not all the time comfortable to use the ticagrelor. Ticagrelor is not so comfortable drug. As the I think there is a spasm in petrosal segment, because before it was no. Yes, it's a spasm. And okay, let's see the venous face. Venozная фаза. Venozная. Нема покажи. Okay, you can see there is a contrast difference in the territory. Yes, here is a stenosis, here is a stenosis, and also the same stenosis on the left side, left transverse sigmoid sinuses are hypoplastic, but at this part you can see additional venous drainage. It might be sign of hypertension. Yes, this all these additional veins. If we will do the angio from the right side, it will be the same. And here is a stenosis, here is a stenosis. There is a diameter difference, and patient has headaches. It's also possible headaches from the aneurysm, but from the experience of venous sinus stenting, usually patients are experiencing improvement after stenting the stenotic sinus. It's approximately 4.8 or more. Okay, let's do it in 45 degree. Ambulance. Abayla in Kazakh language. In English it will be careful. Be careful. Okay. Let's do it like this. Yes, with the stent in the artery there is no problem. Так, Бerdikhojayev. Okay, let's see the stent. Stent is properly opened. Yes, on AP, on lateral, stent is opened and it's covered the aneurysmal segment. It's good. Yes, and now we need to see the venous phase. It's overlaying, huh? Okay. I will go to the right side and we'll check the right territory for the venous venography, and then we can do control CT and finish the case. Okay? Okay. 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 I will do it in angulation. Jet close. Okay. Let's check the right carotid territory. As the arterial phase is not so important, but we need to check the venous phase. Yes, patient has a stenosis, and we will recommend venous stenting in a couple of months. From the previous discussion, patient was not ready for the stenting. That's why we will give a acetazolamide, diacarb for a couple of months. We'll check the headaches, we'll check the ophthalmologist status for the edema of the optic nerve, and then we can recommend the stenting of the sinus. Okay. Okay, let's wait for the control setting. Alt French pingrem so. Dear colleagues, CT is ready. and the brain is clear. Now we'll finish this case, and next case, patient with migraine, with headaches, migraine related headaches, and he has an ictus from the yesterday evening, and today the pain is still there, and we'll do under local anesthesia, lidocaine injection, we'll see. Okay, see you in 30 minutes. See you in 30 minutes. Thank you for watching.